name is Robert Walker, and I'm going to present the results from our randomised control trial on total knee replacement that we performed in Exeter. Most total knee arthroplasty does well. Alignment and balance is critical to kinematics of the knee. With manual instrumentation, there are two techniques commonly used: a traditional measured resection technique and a gap balancing technique. The aim of our study was to compare the functional and patient-reported outcomes of the total knee replacement using two different philosophies: a traditional measured resection and an individualised gap balancer philosophy. In terms of our methods, it was a randomised controlled trial. Patients were recruited from the waiting list of 4 different consultants in the department. And the inclusion criteria were skeletally mature patients that were listed for a TKA using the Corin Ltd knee and were able to consent for the study. Our primary outcome measure was quadriceps strength measured with a digital myometer. Secondary outcomes included validated functional tests as well as patient-reported outcomes, including these. And outcomes were assessed pre-operatively as well as 6 weeks, 3 months, 6 and 12 months post-operatively. Pre-op and post-op CT scans as well as hip, knee, ankle x-rays were performed to assess knee geometry. Overall alignment as well as joint obliquity was compared between the two groups. Looking at the implant itself, it's a cemented implant. It's a single radius of curvature. It's a cruciate retaining, although a posterior stabilized PS version is available and wasn't used in this trial, it was only CL. And the patella was resurfaced in every patient in our trial. In terms of our gap balancing technique, the tibia was cut first. Then this proprietary equibalance device you can see was used to cut the distal femur parallel to the tibial cut in extension. Axial femoral rotation was then set from the tibial cut, balancing the knee in flexion. This was all done with the intention of preserving the soft tissue envelope. In terms of our measured resection technique, traditional, cut the tibial first in 0 degrees. Distal femur was cut 5 degrees from an IM rod, and femoral flexion cut was made 3 degrees of external rotation to the posterior femoral condyles. Subsequent soft tissue releases were performed as required. Looking at our results, 94 knees were randomised into equal groups. Baseline characteristics you can see were matched. Mean age was 70. At 12 months follow-up, 90 knees were assessed. There was no significant difference in the mean quadricep peak torque. KOOS pain subset was statistically better in the gap balancing group at all follow-up points. Range of motion was better at 3 months, and the WeFit balance time to get up and go tests were better in the gap balance group as well, but only at 2 time points post-operatively. Looking at alignment, the pre-operative alignment demonstrated no significant difference between the two groups. Post-operative alignment was actually slightly more in favour of Eyres in the gap balancing group, which was significant. In terms of limitations, there were only 47 patients in each arm. It's a small loss to follow-up, but follow-up was only out to 1 year. In conclusion, our gap balancing technique was associated with better post-op pain, better range of motion, better balance, as well as better time to get up and go. And the gap balancing technique maintained a more constitutional overall alignment without compromising alignment of the implant components.